Good morning, everyone. I'd like to thank Carol for the excellent presentation that she just completed, walking through one of our new measures for LTCH and other post-acute care settings. It is a pleasure to be able to present Section I, active diagnosis, and particularly in the context of the new ventilator liberation quality measures, which I'll be discussing after the break. The acronyms on this particular slide are all familiar to you. The objectives or the overview for this section will be to discuss the intent of Section I, describe the new items and changes, discuss coding instructions for the specific data elements, and walk through a few coding scenarios using the new items. And we're particularly going to be talking about the changes between version 3.0 of the LTCH CARE Data Set and version 4.0. I don't want to put anybody on the spot, but have you had a chance to look at version 4.0 that was posted recently on the website? And I see some nods, so that's great. Thank you. At the end of this presentation, you should be able to articulate the purpose of the item and coding options for each existing, revised, and new items, and also apply these coding instructions to accurately code practice scenarios. The intent of the items in Section I are intended to indicate the presence of select diagnoses that influence a patient's functional outcomes, influence a patient's ventilator liberation outcomes, or influence a patient's risk for the development of or worsening of pressure ulcers. As we all know, a patient's disease processes and conditions can significantly affect a patient's health status and quality of life. In this section, we identify the active diseases and conditions that are associated with the patient's LTCH stay. I'm next going to go over the changes between version 3.0 and 4.0 of the LTCH CARE Data Set. So this slide summarizes the new items and the changes. And as you can see, the list of comorbidities and coexisting conditions have been expanded to address risk factors or risk adjusters that will be used to calculate the two new ventilator liberation quality measures, which I'll be talking about later. I will briefly draw your attention to the new items. As you can see, metastatic cancer and severe cancer are two new items that have been added, and there's a slide coming up that will show you the difference between 3.0 and 4.0. The other thing is that severe left systolic ventricular dysfunction has been added, again associated with the ventilator outcome measure. And also you will see two new neurologic-based risk factors. And all of these that I'm talking about so far were an outcome from input from our technical expert panel related to the over 3-year development of the ventilator quality measures. We had 9 tips, so we had a lot of input in determining how we arrived at these particular, adding these particular items as risk factors and adjusters. The remaining items are associated with organ transplants, and you'll see all of them listed here: lung, heart, liver, kidney, and bone marrow. Again, this was at the advice of our technical expert panel, as well as review of the literature in terms of risk adjusters for the ventilator quality measures. A point that I want to make about the transplant is that when you're coding these, and I certainly will repeat it, this is post-transplant. So this does not apply to patients that may be in your facilities that may be under consideration for a transplant. The next slide provides detail on the change to the severe and metastatic cancer. So in version 3.0, as you know, we had 101, which is severe and metastatic cancer, and as I've already indicated, and Lorraine also pointed this out earlier, that it's now broken out into metastatic cancer and severe cancer, again, at the advice of our technical expert panels, because there are, as you know, different diagnoses associated with metastatic and severe cancer. This definition of active diagnosis is certainly familiar to all of you, and it has not changed. An important component of completing Section I, as you know, is identifying the patient's primary medical diagnoses and determining if they are active. Active diagnoses are those that have a direct relationship to the patient's current functional, cognitive, mood, or behavior status, medical treatments, nurse monitoring, or risk of death at the time of the assessment. Diseases or conditions that have been resolved at the time of the assessment or do not affect any of the patient's factors listed above should not be considered in a patient's current active diagnosis. On the item set, I0050 indicate the patient's primary medical condition category. You're going to indicate the main reason the patient was admitted to the LTCH. And as you are all familiar with, there are four primary condition categories here: acute onset respiratory condition, such as aspiration and specified bacterial pneumonias; chronic respiratory condition, such as chronic obstructive pulmonary disease; acute onset and chronic respiratory conditions; and chronic cardiac conditions, such as heart failure. And as you know, you're going to enter the code of the primary medical condition. If your patient is not admitted to the LTCH for one of these four conditions, then you are going to code this item as 5, and you're going to enter the ICD-10 code for the condition that the patient is admitted for. I had the opportunity to visit an LTCH yesterday and learned in talking with the staff that sometimes when a patient is transferred to the LTCH, the ICD code is in the chart, and then the staff that are completing the assessment are able to easily enter that particular ICD-10 code, and then at other times it requires review of the medical record. As previously mentioned, this item captures the primary medical condition category that resulted in the patient's admission to the LTCH. Next, I'll go over the steps for assessment. The first step for the assessment is to identify the primary medical condition category, as shown on the list in a previous slide. The diseases and conditions in this section require a physician or nurse practitioner, physician assistant, clinical nurse specialist, or other authorized licensed staff, if allowable under state licensure laws, documented diagnosis at the time of the assessment. The second step in the assessment process is to determine the patient's active diagnosis. As previously stated, active diagnoses are those that have a direct relationship to the patient's current functional, cognitive, mood, or behavior status, medical treatments, nurse monitoring, or risk of death at the time of assessment. Patient's diagnosis may be found in any of or a combination of the patient's medical record sources, such as patient problem lists, physician's orders, history, and physical. Although open communication regarding diagnostic information between the physician and other clinical staff is important, it is also essential that diagnosis communicated verbally be documented in the medical record by the physician or designee. Diagnostic information, including past medical and surgical history obtained from family members and close contacts, must also be documented in the medical record by the aforementioned providers to ensure validity, follow-up, and coordination of care. Only diagnosis confirmed and documented by the physician or designee should be considered when coding this section. This slide reviews the primary medical condition categories as previously described. As previously stated, only diagnosis confirmed by the physician or designee and documented in the medical record should be included or used to code this particular section. Once you have entered the patient's primary medical condition, you're going to proceed to the morbidities and coexisting conditions. So now we'll do one practice coding scenario for this data element. Ms. K is a 67-year-old female who is admitted to the LTCH after an acute episode of respiratory failure secondary to pneumonia. Ms. K is on an invasive mechanical ventilation. The admission diagnosis of acute episode of respiratory failure secondary to pneumonia is documented in the progress notes of the patient's medical record by the LTCH admitting physician. How would you code this scenario? So your selections are Code 1, acute onset respiratory condition, Code 2, chronic respiratory condition, Code 3, acute onset and chronic respiratory condition, or Code 4, chronic cardiac condition. Excellent. So 92% selected A, acute onset respiratory condition. That is the correct answer. And the rationale for this answer is that the diagnosis of acute respiratory failure secondary to bacterial pneumonia is a primary medical condition category and is an active diagnosis for this patient, as it will influence her health outcomes. The physician's progress note documents the diagnosis of acute onset respiratory condition secondary to bacterial pneumonia as the reason for the LTCH admission. The next three slides depict the data elements associated with the comorbidities and coexisting conditions component of Section I. If a patient has any of these conditions, a person completing the data set should check all that apply. This section is completed only if A 2050 reason for admission equals 01 admission. You should code diseases or conditions that have a documented diagnosis at the time of the assessment and are active and, as previously stated, have a direct relationship on the patient's current functional, cognitive, mood or behavior status, etc. The expanded list of comorbidities and coexisting condition comprise cancers, heart, circulation, genitourinary, infections, metabolic, and musculoskeletal. On this slide, you see the two cancer data elements, which are metastatic and severe cancer and severe left systolic ventricular dysfunction. Examples of metastatic cancer include prostate cancer with metastasis of the pelvis, stage 4 bladder cancer with metastasis to the lung. Examples of severe cancer might include hepatocellular cancer, glioblastoma multiforme, liver cell carcinoma, and chronic myeloid leukemia. As previously mentioned, the neurologic comorbidities and coexisting conditions have been expanded. The new data elements in this area are I, 5455, other progressive neuromuscular disease, and I-5480, other severe neurological injury, disease, or dysfunction. Nutritional remains the same on the comorbidities and coexisting conditions, and as I've already mentioned, the post-transplant is new, and you see all of the transplants listed here. And again, I emphasize this is post-transplant, not patients awaiting a transplant. And as you currently do, if the patient does not have any of the active diagnoses listed above, you're going to check I-7900, none of the above. This slide just summarizes the changes in categories and conditions between the LTCH CARE Data Set version 3.0 and 4.0. As previously stated, these items capture the patient's comorbidities and coexisting condition. As you know, disease processes can have a significant adverse effect on the individual's health, status, and quality of life. And some disease processes and conditions can influence a patient's health outcomes. As earlier stated in the presentation, the list of comorbidities and coexisting conditions have expanded. A few points of emphasis. There must be specific documentation in the medical record by a physician or designee of the disease or condition being an active diagnosis. The physician or designee may specifically indicate that a diagnosis is active. Specific documentation areas in the medical record may include, but are not limited to, previously mentioned sources of documentation. The physician or designee, for example, documents at the time of assessment that the patient has inadequately controlled diabetes and requires adjustment to the medication regimen. This would be sufficient documentation of an active diagnosis and would require no additional confirmation because the physician documented the diagnosis and also confirmed that the medication regimen needed to be modified. For the purpose of the long-term care data set, LTCH should consider only the documented active diagnosis, and you're going to check all that apply. A diagnosis should not be inferred by association with other conditions, such as weight loss should not be referred to mean malnutrition. This slide just summarizes the entire section I, all the comorbidities and coexisting conditions that are available for you to select. One of the things that I'd like to note on here, we've gone over the metastatic and severe cancer. The data element under cardiac, this severe left systemic ventricular dysfunction is defined by the patient's ejection fraction. So you're going to code this item if the patient's ejection fraction is less than or equal to 30%. So I just want to make that point clear. For the sake of time, I'm going to move on to more practice scenarios. Okay. Mr. F is admitted to the LTCH for medication administration, pulmonary assessment, and speech-language pathology therapy post-hospitalization for aspiration pneumonia due to dysphagia. Included in the physician's history and physical assessment is the diagnosis of Shy-Drager disease, which is multi-system atrophy. How would you code this scenario? Indicate the patient's primary medical condition. So your choices are acute respiratory condition, chronic respiratory condition, acute onset and chronic respiratory condition, and chronic cardiac condition. And the majority of you picked C, acute onset and chronic respiratory condition. In this scenario, the response is acute onset respiratory condition. Which comorbidity and coexisting condition would you check in this scenario? And the majority of people selected C, other progressive neuromuscular disease, which is correct. So in terms of explaining the coding, in this scenario, the patient's primary condition category is acute onset respiratory condition, so you would code it 1. And the coexisting condition is an other progressive neuromuscular disease, I-5455, would be checked, which is the patient's Shy-Drager disease or multiple system atrophy. The next coding scenario is Mrs. P is admitted to the LTCH after a bone marrow transplant. The hospital transferred record indicates a signed discharge summary with a list of diagnoses including aplastic anemia and allogeneic bone marrow transplant. She is receiving medication and is being monitored for signs and symptoms of transplant rejection infection. Which comorbidity and coexisting condition would you check? Okay, excellent. C, you would check bone marrow transplant. I-7104 would be checked bone marrow transplant as the patient was admitted to the LTCH post bone marrow transplant. She is receiving medical treatments related to the bone marrow transplant, and the hospital transferred record indicates a signed discharge summary documenting this diagnosis. The next coding scenario, we have a patient who had a surgical removal of a spinal cord tumor at the level of T6 and a diagnosis of complete paraplegia. The physician's progress note documents the diagnosis of malignancy and the need for further treatment with chemotherapy and radiation. Which comorbidities and coexisting conditions would you check in this scenario? Okay, 50%, it looks like, I'm having troubles reading these, as you can probably tell. 50% selected both B and C, and another, it looks like 46% picked D, both A and C. So the correct answer is E, both B and C. Severe cancer, I-0104, severe cancer, and I-500 paraplegia would be checked, as these are both considered active diagnoses for this patient, as both were documented in the physician's progress notes and could have a direct relationship to the patient's current functional, cognitive, or behavior status, medical treatments, nurse monitoring, etc. I have about 5 minutes left, so we'll continue with the next scenario. A patient is admitted to the LTCH after a stroke. The admitting physician has reviewed the record of the hospital course and performed and documented the history and physical, indicating the stroke occurred in the postoperative period following a kidney transplant. He also writes the patient is receiving parenteral nutrition as he is at risk for malnutrition. The patient has right-sided hemiparesis and neglect identified in the transfer report from the hospital. Which comorbidities and coexisting conditions would you check in this scenario? Stroke, hemiplegia or hemiparesis, risk for malnutrition, kidney transplant, or all of the above? Excellent, 100%, all of the above, very good. I love hearing the discussion at the tables as I'm standing up here as you're deciding which ones to select. So so that is the correct answer. So you would code, as you did, stroke, hemiparesis, patients at risk for malnutrition due to neglect, and a status post a kidney transplant. The patient's functional status, medical treatments, and monitoring requirements are directly related to the diagnosis of stroke with right-sided hemiparesis and post-kidney transplant. All of these diagnoses are documented by the physician in the patient's medical record documentation. In the last scenario, we have Mr. B, who is admitted to the LTCH with the diagnosis of status post-heart transplant for severe cardiomyopathy and end-stage heart failure. The hospital discharge record includes an extensive cardiologist report which documents an echocardiogram result of an ejection fraction of 15%, a diagnosis of severe left systolic dysfunction, and long history of cardiomyopathy with end-stage heart failure. The signed heart transplant surgical report is also included in the hospital transfer notes. Nursing care includes cardiopulmonary monitoring as well as post-transplant assessment. How would you code I0050 for this patient? Okay, great, 100%. The correct answer is code 4, chronic cardiac condition. In this scenario, what comorbidities and coexisting conditions would you check? A, severe left systolic ventricular dysfunction, heart transplant, none of the above, or both A and B? 91% selected both A and B. That is the correct answer. So to summarize this scenario, you're going to code I0050, indicate the patient's primary medical condition is chronic cardiac condition, as you did. And then for the coexisting and comorbidities, you are going to select severe left systolic ventricular dysfunction because the patient's ejection fraction was less than 30%, and also it was documented in the medical record, and this patient also had a heart transplant. So in summary, I have flown through section I to review what are captured in section I in terms of active diagnosis and coexisting and comorbidities. As you know, the primary condition category and comorbidities and coexisting conditions must be documented in the patient's record upon admission to the LTCH. We've also, in this session, identified the primary medical condition associated with the LTCH admission and report that primary medical condition. As you know, if on item 1050A, if other medical condition is coded, enter the ICD code for other medical condition. The list of comorbidities and coexisting conditions have expanded, and you're going to check all that apply. In terms of action plans, obviously, what you're going to want to do is review section I, looking for those go over with your staff those new coexisting conditions and comorbidities. You're going to want to reinforce with your staff that they should not be inferring a diagnosis from documentation that is not consistent with the specific diagnosis. This completes this presentation of section I, and because I went through it so quickly, please submit questions either from the slips that are on the table or electronically. And now it is time for break.